Welcome to the Silent Radiologist, where complex radiology becomes clear, simple, and powerful. Chest X-ray is the most common yet most misunderstood investigation. In the next 4 minutes, I'll make CXR interpretation simple, fast, and unforgettable. Every doctor must know how to read a chest X-ray, but the key is a structured approach. Always start with quality check using the RIPE method: rotation, inspiration, position, exposure. Rotation, clavicles equal distance from spinous process. Inspiration, 9 to 11 posterior ribs visible. Position, differentiated PA versus AP chest X-ray. Exposure, in very good exposed chest X-ray, vertebrae seen behind heart. Now the easiest and safest method: ABCDE, airway, breathing, circulation, diaphragm, everything else. Start with the airway. The trachea should be central. Look for deviation which may suggest tension: pneumothorax, fibrosis, pleural effusion, atelectasis, or masses. Next, evaluate the lungs. Compare both sides. Look for consolidation, pneumothorax, pleural effusion, or hyperinflation. The heart should be less than 50% of thoracic width on PA view. Check the mediastinum for widening, contours, and aortic arch. Check the diaphragm and bones, fractures, lytic lesions, and diaphragm for free air or elevation. Finally, look for tubes, lines, surgical clips, soft tissue shadows, and hidden abnormalities. Okay, let's understand chest X-ray PA versus AP. Rule number 1, in PA view, the patient stands facing the detector and the X-ray beam hits from the back. Result: the heart looks smaller and more realistic. This is the view we love. But in an AP view, usually done in sick, bedridden patients, the beam comes from front to back. And here's the catch: the heart looks bigger, sometimes falsely enlarged. Don't fall for it. On a chest X-ray, here is the simplest trick to avoid getting confused. Posterior ribs are the ones you see clearly and horizontally, because the X-ray beam hits them first. They're closer to the tube. The anterior ribs look fainter and more curved downward as they wrap toward the sternum. Now watch what changes in PA versus AP views. In APA view, the patient is upright and the heart is farther from the detector, so ribs look crisp and magnification is minimal. But in an AP view, like in bedridden patients, the heart and anterior ribs sit closer to the tube, so everything looks more magnified, softer, and the anterior ribs stand out a bit more. That's why identifying rib orientation instantly tells you what view you're dealing with.